Hey peeps, welcome back. So today we're going to go through cervical cancer trials, some newer trials from 2023, 2024, and kind of put them all together to make some sense, mostly on induction chemotherapy, consolidation chemotherapy, chemo-RT, and then immunotherapy with chemo-RT. It's really dense. I hope you get a piece of paper, and I really encourage you to read all these trials on your own. That's the way you're going to learn it the most, but let's get started. Okay, so we're going to go over these 4 trials here. They're mainly focusing on chemotherapy in cervical cancer in different phases of chemotherapy. And then we won't touch on surgical trials today. These are actually a little bit more straightforward, so I think that you can read those on your own. Immunotherapy, I have some previous lectures on some immunotherapy in cervix cancer, but and we can go over that in the future. But then after we go over systemic chemotherapy, we'll look at immunotherapy plus chemo-RT. We won't do these 2 trials today. Okay, so if you don't have an NCCN guidelines login, it's free. I encourage you to get one at any level, even as a resident, even as a medical student. So we're mainly going to be focusing today on locally advanced cervical cancer. And I remember when I had first started, I didn't know what locally advanced cervical cancer even meant. When I first started as a medical student, not this lecture, but in these cases, we're going to be talking about stage 1B2 through 4A. One trial includes 1B1 with positive nodes, and most of these patients are not wouldn't qualify for surgery, and so locally advanced cervical cancer. And this is going to be the NCCN page that leads us to these trials, and I'll reference back to this a couple times. Okay, so first let's just talk about systemic chemotherapy. We're going to talk about those 4 trials that I mentioned: Outback, CXII, EORTC 55994, and then Interlace. And so reference these icons. This is not going to be a fun lecture. It's going to be informative, but maybe not fun. And I usually like to put a lot of photos in, but unfortunately, these don't lend themselves to many photos. So I try to put these icons in because I learn best by pictures. So this is going to be the icon for systemic chemotherapy. This is going to be your chemo-RT icon, because we're going to get these confused. What does chemo-RT come first? Does systemic therapy come first? When does surgery come into it? And so I have some icons scattered throughout this presentation to try to help a little bit, but whatever works for you. So these aren't really in any particular order for the presentation. I think we're going to go over EORTC first. This talked about chemo and then surgery after chemo versus chemo-RT, negative. And then Outback was chemo-RT followed by chemo. I think we were all very hopeful for this trial. It was negative. And then this was a phase 2 trial, CXII, which did show some response. It was chemo followed by chemo-RT. Notice the icons. And then these 2 trials led into the Interlace trial, which we'll go over, which was actually a positive trial. So let's get into it. Okay, we'll first start with EORTC 55994. This asked, can neoadjuvant chemotherapy followed by surgery improve outcomes compared to chemo-RT alone in locally advanced cervical cancer? And when I say chemo-RT, I mean chemoradiotherapy, and the chemotherapy is cisplatin. There were around 600 patients, stages 1B2 through 2B. The surgery arm had 2 or 3 cycles of chemo, and that was followed by a radical surgery. And then the chemo-RT arm was our typical EBRT followed by brachytherapy. The primary endpoint was overall survival. The follow-up was 8.7 years. 71% of patients completed in the neoadjuvant surgery arm, 82% in the chemo-radiotherapy arm. And I'm not going to read off all the things on the slides. A lot of this is for my studying in the future, and so I just wanted the information on there. And hopefully you find it useful too, so you can read off of the slides. I'm going to talk about the things that I find important. So this is one of the really important parts, was that additional radiation was used for a large, almost 50% of patients in the neoadjuvant surgery arm. So that's really a lot. And then the 5-year overall survival was not significantly different between the two arms. So this trial failed to demonstrate superiority in favor of the neoadjuvant surgery arm. We talked about the additional radiotherapy that was used. And the paper talks about, if anything, that the upfront chemoradiation provided better disease control with a higher progression-free survival, and then spared many patients of the added burden of 3 modalities, because the chemo people also got surgery, and then half of them needed radiation. And so there's that trial. So next we have CXII. This was a phase 2 trial looking at the feasibility of weekly neoadjuvant chemo followed by chemo-RT for locally advanced cervical cancer. The rationale was that a short course of upfront chemo might shrink the tumor and treat micrometastatic disease, and therefore improve subsequent disease control with chemoradiation. The primary endpoint was response rate at 12 weeks. And they looked at the response rate after the chemo. So because they did chemo first, they looked at response, 70% response rate. And then they looked at the response rate again after chemo-RT, and that was 85%. 39-month follow-up. And then they looked at overall and progression-free survivals. And this showed a high tumor response rate. And so it was a phase 2 trial. It was idea generating, and it led into the next trial, which is Interlace. And so Interlace asked, can giving chemo prior to chemo-RT improve outcomes in locally advanced cervix? It was a phase 3 trial, stage 1B2 to 4A. The control was chemoradiotherapy with the doses here versus experimental arm, which was 6 weeks of induction chemotherapy followed by standard chemo-RT. Okay, so stay with me here. Remember, we're discussing chemo-RT alone versus chemo followed by chemo-RT. And the primary endpoint was overall survival, and PFS was secondary. There were 500 patients. And induction chemo before chemo-RT did show a significantly improved 5-year progression-free and overall survival. If you look down here at the overall survival, 80% induction with chemo-RT and 72% in chemotherapy alone. The study discusses toxicities, and the conclusion of the study was a short course of induction chemo followed by chemo-RT improves survival of patients with locally advanced cervical cancer. There are some concerns that the study population had relatively low-risk disease. There only about less than 15% of patients had stage 3 or 4 disease, and I think 60% of patients had negative nodes. And then concern is expressed about delaying curative chemo-RT if hematologic toxicities occur in the induction chemo group. The authors in the paper discuss that although chemo-RT is curative treatment for about 75% of patients, that increasing this by 7 to 10% represents a clinically meaningful improvement at a relatively low cost of these chemo drugs. So you'll see here, this is the NCCN guideline slide that I showed earlier. This little P footnote has been added, and it does mention induction chemo based on Interlace guidelines. So there's that. And so the last trial in this group is the Outback trial. And I think this got a lot of press when it came out, but it was asking if someone got chemo-RT and followed by adjuvant chemotherapy, could that improve outcomes in locally advanced cervical cancer? It was a phase 3 trial, stage 1B1 with positive nodes through 4A, and it was standard chemo-RT versus chemo-RT then followed by 4 cycles of carbotaxol, and the doses noted here. Primary endpoint was overall survival. There were over 900 patients in this trial, and in conclusion, the addition of adjuvant chemotherapy did not improve overall survival. And the conclusion was that standard chemo radiation should continue to be the standard of care. Okay, so here's a summary of the trials that we just discussed. The CXII trial showed some response, and this set the stage for Interlace in the future. EORTC and Outback were both negative trials. However, they have given us good information to make clinical decisions in the future about these topics. And then Interlace, which is now in the NCCN guidelines, induction chemo followed by chemo-RT, a statistically significant result. So I hope that this has helped you keep this information organized as it has helped me go through the information. And let's move on to immunotherapy. Okay. If you're still with me, we'll move on to immunotherapy with chemo-RT, but we'll briefly, I'll just note the other trials here. This is a nice excerpt from Dr. Tawari, who set, and this paper is really nice if you want to read it, but the proof of concept was realized in 3 practice-changing trials of immunotherapy, BEAT-CC, KEYNOTE 826, and then EMPOWER. And so I've listed those here with their titles. And then also there's another trial here, Compassion 16, that came out last year that we're not going to discuss today, but maybe in the future you can look it up on your own. Okay, so immunotherapy with chemo-RT, 2 studies that we'll go over here. And the conflicting outcomes have led to some speculation about differences in the efficacy between PD-L1 inhibitors and PD-1 inhibitors. And we'll go over those 2 trials right now. So the CALLA study, it was durvalumab versus placebo with chemo-RT for locally advanced cervix. Phase 3 trial, previously untreated, stage 1B2 to 2B, lymph node positive or any stage greater than 3. Durvalumab with the dose here was given versus placebo with and following cis-RT for up to 24 cycles. So they did get maintenance therapy, and the primary endpoint was progression-free survival. There were 770 patients. The progression-free survival was not significant in this study. It was a negative study. At 12 months, the PFS was 76 with durvalumab, 73% with placebo. And in conclusion, this did not improve progression-free survival. That leads us to the KEYNOTE study, A18. And this also asks the question, can the effect of chemoradiotherapy be enhanced by immunotherapy? It was a phase 3 trial, and it used pembro instead of durvalumab. Stages here, 5 cycles of pembro every 3 weeks plus chemoradiotherapy, and then followed by maintenance pembro. Very similar. It had about 1,000 patients. And when they did their analysis, the median PFS was not reached in either group at 24 months, 68% in the pembro chemoradiotherapy group and 57% in the placebo chemoradiotherapy group. And OS at 24 months, 87% pembro chemo-RT, 81% placebo chemo-RT. And the conclusion of this study was that pembro plus chemoradiotherapy significantly improved progression-free survival in patients with locally advanced cervix cancer. NCCN also has added pembrolizumab, but they do stipulate that only for patients with stage 3 through 4A disease. But it is the first positive phase 3 trial showing that adding immunotherapy to chemo-RT improves PFS in locally advanced cervix cancer. And so you'll see here, I screenshotted NCCN guidelines again, and this is chemoradiation preferred regimens, cisplatin plus pembro, category 1 for stage 3A, 3B, and 4A, based on FDA approval here. Okay, so that's that for today. If you're struggling to keep these straight, these are all added to our question bank, so feel free to give it a try. You can always reach out to me if you need any help or any questions about it, but I'll put the link in the description. Here are all my resources. Let me know if you have any questions. I hope this was helpful. These trials are confusing. Hopefully there's a way that you can keep them straight and reference this for later use. Thanks.